looked at the indicators, we actually appreciated that we were able to assist. They said home deliveries actually have reduced. DHI, for us, it has been a blessing actually. My name is Evans Mwananyambe. I'm the Monitoring and Evaluations Officer for Access to Health Zambia. Specifically, there is a project that we are running in Mwandi, which is called CHAMPS, Children and Mothers Partnerships. We support the whole district. We have community health workers in all the 68 zones of the district. From my part, from the project's point of view, I think DHIS2 has been really instrumental in our programming. Luckily enough, our project is not static. It's not rigid. So we respond to the problems that we actually identify in the community. And DHIS2 has been very instrumental in actually pointing us to the direction of where we should concentrate our resources. So what we do as a project is we implement activities that target at improving mother and child health indicators at community level. Once they are improved at community level, meaning we are also targeting facility level indicators. Basically for DHIS2, the data users from one end. On the other end, we actually train our community health workers to actually collect community data, which is aggregated into the DHIS. So once that data is aggregated and reported through DHIS2, so we look at the indicators now through the data that we get from DHIS2. So that data, that's the one that we use now to come up with targeted interventions at community level. As a project, we actually implemented a community health worker strategy where we brought on board some community health workers to conduct household visitations. So when we looked at DHIS2 data to do with deliveries, we actually noticed that we were having many deliveries happening at community level. It was as high as 50 home deliveries per 1,000 deliveries in the district. So when we investigated that, some of the reasons that the women gave were that one, they didn't have transport to go to the health facility for delivery. So that was a challenge for them because they couldn't walk, and our situation is our district is impoverished and there is no road network to talk about. So to respond to that challenge, the project actually procured ox-drawn ox carts for all the neighborhood health committees in the district to at least help the neighborhood health committees to assist the women to at least attend antenatal care, and also community referral to the health facility for delivery. Secondly, the women also complained that they were not prepared for the birth. The birth preparedness was not there. They didn't have the resources to actually be able to buy things like baby blankets and stuff like that. Again, as a project, we implemented some help to assist the women to have birth preparedness. So we bought them baby mama packs where there is a baby blanket and some nappies and some wrapper and all those things. And that really helped. And the other challenge was that even as they managed to go and deliver at the health facility, due to our situation, as I already alluded to, the distances that they have to cover to the health facility. So we encourage that they go and at least a month before delivery, they go to the health facility to wait to deliver. But then assessing the waiting homes that they go to at health facility, again, we noticed that they were not conducive for them. So we ended up as a project to start building permanent maternity waiting homes. And this has really helped actually generate good indicators for us as a project and the district health office as well. Before noticing the home delivery, there were around 50. But now we have seen a reduction to somewhere around almost half of that. That's like we've reduced them by 50%. We know we cannot eliminate, but we know we can reduce as much as possible. And the CHWs are the ones that actually make sure that there is a referral, a maternal referral from the community to the health facility. So they have registers again for the pregnant women to make sure that when the time to move to the mothers to the maternity waiting home comes, they should be able to remind the pregnant women and continue encouraging them to go to the health facility to have a safe delivery. It's not just maternity waiting homes, but also even in health facilities. We have built health facilities in areas where, again, we had issues of the same home deliveries which we noticed from DHIS2. So we have an area that was very problematic with home delivery. Consistently, on a monthly basis, you have home deliveries in that area. When we look at that area, we noticed that the area is actually very far from the nearest health facility. So the women, even just for ANC, will have to jump on a vehicle, public transport, go all the way to the district hospital, which is about 20 kilometers from the community. So that was one of the contributing factors. The distance was too long. So what we did was we have actually completed building a health facility there in that community, so that now our pregnant women will not have to walk longer distances. They will not have to deliver at home when they have a health facility close to them. Actually, before we started using DHIS2, even just coming up with our own project annual report used to be very difficult. Prior to 2018, most of the reports that we used to write as a project were more on the narrative part than on the data-driven part. But once we started using DHIS2, things became even easier. We actually standardized our reports. I think that's one positive thing that as a project we have benefited greatly from DHIS2. So when we do our reports, like our quarterly report, the data that we get on MCH and indicators comes from DHIS2. So it is greatly improving people's lives. I may not be able to actually maybe tell the picture as it is. I wish there was an opportunity to go to the communities and talk to them themselves. It's really improving.